Imagine me trying to give you a talk about the importance of taking care of people in their own homes 200 years ago. As an audience, 200 years ago, you would have probably looked at me and said, what an irrelevant talk. What's so special about taking care of people in their own homes? We all do it all the time. It's the way it had been done since the first person with a medical issue in a cave met the first healer. Where else would you take care of a person if not in the comfort of their own home? Well, history is coming back. Hospitals have been around since the early days of the Greek and Indian empires. And although they've changed with time, civilizations, wars, have you not, they remain pretty much what they were in the beginning. Mainly religious institutions, not medical ones. You would go there either because society has driven you out, like in the case of leprosy, or you'd go there to die, or the combination of the two. It's only in the last 200 years that medical pioneers such as Thomas Percival and Florence Nightingale have changed, modeled, and remodeled hospital care pretty much to the way that we know it today. In the last 200 years, the pendulum of place of treatment has shifted all the way from the homes to the hospitals. And the sight of a medical team making regular home rounds to acutely ill patients is one that most people have never or rarely see anymore. In the few cases where it still happens, it's mainly for elderly, chronic patients in home hospice rather than homebound, hospital-worthy acute patients. Well, we're sitting here today because we all believe that history is coming back. Pretty much like the largest taxi company in the world has no taxi car of its own, Uber, and the largest hotel company in the world has no hotel rooms of its own, Airbnb. Most of us believe that in the very near future, the largest and most comprehensive hospitals in the world will have no hospital beds of their own. Medicine is going back home. It's going back to the homes of our patients. And although this is the natural course of event, and this is the way it has been done for many, many, many centuries, for us as medical providers, it's all about going back to school. It's all about going back to school and learning how to do it right all over again. Because although it's still about patients, healthcare providers, and medicine, they are not the same patients they were 200 years ago. We're not the same healthcare providers, and it's definitely not the same medicine. I was trying to think of an example of something which at one time is a natural process to do, and then one time you stop doing it, and then trying to do it again is a complex issue. And one example I could think of was living with your parents. When you're born, the most natural thing to do for a lot of us is go live with your parents. And we do it for a while, and then we leave our parents' home, again a natural thing to do. Now after many years, when you're a grown up, try and go back and live with your parents. Okay? They're still your parents, you're their child, and it's their home, but they're not the same parents, you're not the same child, and it's definitely not the same home. You need to learn how to do it all over again. And although we're sitting here and we're telling everybody and ourselves, and we believe it, that home hospital is the best option, because less infection, less risk of deteriorating cognitively, less risk of falling, what have you not, and we're probably right. But it's not all that, it's not 100% okay. We need to be wary of something. And that something is the notion that paradoxically, taking care of a person in their own home is paradoxically a situation where both sides are more vulnerable. Both the healthcare providers and the patients. As healthcare providers, we're more vulnerable, both professionally and emotionally. Professionally, we're more vulnerable because there are no CT scans, no MRIs at home, in most cases not even a simple X-ray machine. No immediate access to a complicated laboratory work or a panel of consultants. What we have between our ears is the toolbox. Emotionally, we're more exposed because there's nothing to hide behind between us and our patients. There are no large waiting rooms, no eagerly protective secretaries, no enthusiastic interns, in most cases not even a large desk that we can sit behind. Nothing to shield us between the patients and their emotions. So essentially, what we know and how we act is what we have. Patients are more exposed in their own homes, Because we all know the saying that a person's home is his or her castle. And for a lot of people, when the medical teams come to their castle, they might feel like it's an intrusion or an invasion. A lot of people, when they leave their home, or most of us, when we leave our home, we wear a costume. We decide what we want to present to the world, what to bring with us when we meet the world, and what decide to leave back home. And it doesn't matter if we're going to work, visit friends, or make it to a doctor's appointment. But when we go to our patients, to their homes, they can't really hide. They're exposed. And for a lot of them, especially in today's norms and standards, that might feel very intrusive. I learned a very, very important lesson about the difference between what people bring with them to an encounter with the medical profession and what they decide to leave at home. Many years ago, as a young medical doctor, a young medical student, I earned a scholarship to go have a month-long elective in family practice in a clinic in the center of London. And the clinic was run by the late Dr. John Cohen. Unfortunately, he died since. And Dr. Cohen met me on the first day of a 30-day-long elective, and he told me that before I get the chance to sit with him in the clinic, I have to sit in the waiting room for 3 days. He said a family physician must acquaint himself with the dynamics of a waiting room. And he was, of course, absolutely right, and I thank him for this lesson. And in that waiting room, listening to patients talk to each other and listening to them talking to the staff, I learned that for patients, the actual visit started many days before they arrived to the physician. For us, once they opened the door, that's when the visit started. But for patients, it started many days before when the first, they felt that. And they ignored it, but they decided to ignore it. And then a few days later, it was like, no, should really get this checked out. And they take the time and they make the appointment to go to the clinic. A few days pass and thoughts start running in their heads, mainly anxiety-driven thoughts. And the actual day of the appointment arrives and more anxiety-driven thoughts. And by the time they're sitting in the waiting room, their thoughts are running at 1,500 kilometers an hour. But by this time, they had time to get ready to the meeting. They had time to practice, to rehearse, if you will, their part as patients. And they have an option, even though it's a theoretical one, to make a U-turn and go back home and cancel the visit altogether. They can decide what to present to the actual encounter and what to make an excuse about something else. They can decide what not to bring to the encounter altogether and leave at home. All this is gone when we enter their homes, especially in the acute hospital at home acute setting. When we usually come with very little head notice, we come a few times a day, and sometimes a few of us together. At this situation, the patients have no time to get ready, to practice, or to rehearse their part. Excuse me for a second. In this situation, they had no time to don their costumes or to rehearse their part as patients. They can't really not show up for the appointment. It's their home. They can't really hide everything because we see them, and they can't hide the true reason of why the visit is there. So no reason that for a lot of them, this might have the potential of feeling very intrusive. Patients have no time to rehearse their part for this specific occasion. A lot of them, it's the first time occasion and maybe the only time they'll ever have an acute care team in their homes. Now, they've been very well practiced in the part of coming to our clinics. They've been doing that ever since they were children. They know how to play the part of the guest in our hospitals and clinics. But now we're asking them to play a different role. They need to play the part of the host. And they're sitting there and thinking different thoughts than they would in the clinic. For example, should I offer the team something to drink? Should I offer them something to eat? Do they keep kosher? Is it okay that I'm sitting in the living room? Should I move to another room? What's my role here? Now imagine that I'm a person who's very meticulous about how my house looks before guests come over. I want my house to look like a shiny museum when guests come over. Now I'm sick enough not to do all that. And I'm sitting there, and whilst the team is taking care of me, my thoughts are thinking, are the dishes in the sink? Is the floor clean enough? Did I dust the bookshelf? All these are thoughts that are extra over and beyond the usual thoughts that I have as a patient. Will I get better? When will I get better? Can I trust this team? Is this medication making me feel better? Etc. So no wonder that for a lot of people, they feel not in control of the situation. Now, it's one thing to feel not in control when you're not in your natural territory, when you're in a hospital or a clinic. It's a whole different thing to feel not in control in your own house. And for a lot of people, that's what we call cognitive dissonance. It's a source of anxiety, or could be a source of anxiety. We've all had professionals come to our house, all of us. Cleaners, various technicians, delivery people. We know how to act in this situation. And usually in this encounter, we feel like the stronger part of this unequal equation. But when we're sick enough for a hospital team to come to our house, in this specific encounter, we might feel like the weaker side. Imagine, if you will, that this encounter between patients and a healthcare team is a show. It's a play. And when this play is acted out on a stage in a hospital, then the spotlight is on us. It's on the caring team. But when this play is acted out on a stage, which is in the patient's home, we must realize that the spotlight must be on the patients, not on us. So how do we do it? How do we do it right? What's the secret ingredient that we must add to this already intriguing art of taking care of people in their own homes? I really wanted to know the answer to this question. So we looked it up. Unfortunately, there's practically zero information about it in the medical literature. We did manage to find a protocol for social workers on how to make their home visit, a little bit more efficient and maintain their self-safety. Very important points, but not what we were looking for. So we decided to tap into the common knowledge of the Sabar health team, which we roughly calculated to be 4,000 years of professional wisdom. And we asked our teams a very simple question. What do you do differently when taking care of a person in their home than you would if you were taking care of them in a hospital? A very simple question. And we got tons of answers back. A lot of words came back. And because it was so much work, I needed an assistant, and I used the assistance of Mrs. Moran Weiss, who's the head of social workers at Sabar Health, and my wife, Ronit, who's also a social worker. Great with words. And we went through everything people wrote us. And the first thing we did is excluded out all the things that we call universal traits. Universal traits are things like compassionate, kindness, listening, being there, all these things, because these are universally true. It doesn't matter if you're taking care of a person in a hospital, a clinic, in their home, the jungle, or the desert. They're always true. But when looking at all the other qualities, we notice that there's one theme that hovers above it all. And that theme is that when you're taking care of a person in his own home, you're first and foremost his guest. You're a wanted guest, you're a needed guest. In some of the cases, their lives depend on you, but you're still a guest. Now, you're not a regular guest because you're a professional at what you do. You need to be the best at what you're doing, the best doctor, the best nurse, the best social worker, the best physiotherapist. But you should also be a professional in the sense that you know how to do that specific profession in a surrounding that's not yours. And that's why we coined the term the professional guest. And I want to introduce to you now the 4 tools that we think are essentials in becoming a better professional guest. The first one is observe and absorb. When you enter a person's house, look around, scan the house. Look for anything or everything that will teach you about this person's sources of strength and reasons for weakness or challenges. Things like, are there recent photographs of family members on the walls, on the fridge? Is there food on the fridge? Are there fresh flowers in the vase? Is there somebody important to that patient always present in each and every one of our visits? The answers to these questions will give us information to two important issues. One, establishing initial trust, and tailoring a specific care plan. Establishing initial trust is crucial if we remember that for some of the people, interaction in their house might feel very intrusive. So what I suggest to you is find something in the house that you scanned for that you can compliment about. Look around. For example, if I walk into a living room and on the walls there are paintings, all signed E. Gonzalez, E. Gonzalez, E. Gonzalez, E. Gonzalez. And the patient's name is Emilia Gonzalez. So the simplest thing is to say, Mrs. Gonzalez, are these your paintings? And if she says yes, compliment her about that. What it is, the simple gestures show that you care, that you realize that you're not in your own territory, that you looked around, that you're a kind person. And that creates initial trust. In almost every house in the world, there's something to compliment about. A set of trophies for the recent bridge tournament, a nice collection of antique books, great view from the window, something. And in those houses where there's nothing to compliment about, acknowledge that as well. Wow, you live in the fourth floor without elevators. That must be very, very difficult for you. Again, what you did is show that you care, that you looked around, that you know that you're not in your natural environment. The other thing in observing and absorbing is tailoring a specific care plan. Now, we all know the plans that we give our patients when they come to us to the hospitals or clinics. Meticulously planned out algorithms and charts with the name of the medication, the times of the day when they need to take it, sometimes with little icons saying if it's morning, lunch, or afternoon to overcome language barriers. Great looking. Now, all of us, if you're experienced enough in the art of taking care of people at home, you had that specific visit when you tried to open the door to your patient's home, and it was stuck on a pile of newspaper that was never thrown out since 1952 till today. With a pile of laundry, with dishes that were never been washed, with anything that you could collect from the streets, and all the stuff that they never threw away. Okay? We all been to these houses. Now, for this patient, this is his specific safe zone. We need to be able to take care of him in that house. That's his castle. What do you think this patient will do with this sort of meticulously planned out chart? Probably just store it away with another pile of paper. This specific patient needs a plan that every day will go in and tell him or her what to take, when to take it, and make sure they take it. Now imagine going into the absolute other direction of a person who's OCD, where all his gray sweaters are arranged by shades in his closet. And imagine telling this patient, well, each day we'll figure out what to do. We'll make it up as we go along. Maybe today this, maybe tomorrow that. That's not going to work. Now, these are the two extremes of patients, and all our patients are somewhere in the middle. What I'm saying is that there's a reason why adherence to medications is about in the low 30%. There's a reason. Because when we write out these charts, we don't know what patients are doing 99.99% of the time when they're not with us, when they're in their natural environment. And going into patients' homes give us a great opportunity to see how they live and where they live, and use this information to tailor a specific care plan for them. And I'm quite sure that will enhance dramatically the adherence to their care plan. Tool number 2. Be prepared to be surprised and improvise. Okay? We're not working in our own territory. We're not in our safe zone. We're entering other people's homes. We need to adjust each time to the next surrounding. That's part of the reason probably why when comparing time of visit per patient, home visits take dramatically longer than hospital visits because we need to adjust. Now, we have no idea what's going to be behind the door when we open the door. Surprise, surprise. Sometimes they're nice surprises, really nice people, great homemade cheese that they give us to taste. They're great. But sometimes they're very unpleasant surprises, neglected surroundings, and although very willing, completely incapable primary care provider, simply an unsafe environment for either the patient or for us. Sometimes the encounters are amusing. I remember my first visit to an Arab village not very far from where I live. First time I came as a physician, as a home care physician. It was in the late afternoon, and I was expecting to find some family members in the house, only to open the door and find that the patient was lying in the middle of the living room with about 90 people in the living room with him, ages 3 months to 95. Now, what do you think I can do? Just say, okay, everybody out, it's not visiting times now. That's not going to work, okay? So what you need to do in this situation is improvise, create an intimate, professional environment for you, the patient, and the family, and make it as professional as you can, even though you have 180 eyeballs looking at the back of your neck, okay? Now, can we write and be prepared for each and every situation, every possible scenario? The answer is obviously no. We do need to switch our minds to be agile, flexible enough to be prepared to be surprised, and have very specific protocols to what to do in specific situations. For example, when the patient or when we feel that we're in danger. That should be very airtight on how to act. Now, to give you an example of improvisation, I remember looking once in one of our male nurses' medical kit, and I saw a hammer and some nails. I said, we're not performing orthopedic surgeries yet at home, so why would you need a hammer and some nails? And he said, this is the way I can make sure that no matter which house I go into, I have somewhere to hang an IV line. Now, I think this is brilliant. This is a classic example of being a good professional guest, because what this nurse is saying is that no matter which house I go into, I can make the patient feel secure enough that they'll get the best treatment regardless of what equipment they have at home. And I think that's wonderful. The third tool is ask for permission. Ask for permission. It sounds almost intuitive, the polite thing to do, but I say exaggerate it. Before you enter the house, when you give them a call, is it okay if I come tomorrow between 4 and 6? Can I come in? Is it okay if I sit here? Can I go to the toilet and wash my hands before I check you? Is it okay if I sit at the desk and write my prescription? Can I hook up my computer to your electricity? Ask for permission for everything. It sounds simple, but it gives the patient the sense of control. They're in control. It's their house. You're in their territory. Now notice I didn't tell you, ask for permission, is it okay if I check your lungs now? Because again, that's universally true, no matter where you're working. You always have to ask the patient permission for these things. But for the rest, ask for permission when you're in their home. The fourth and the last tool is set the grounds for the times that you're not there. After establishing initial trust, families and patients feel very safe and very secure when their teams are present in their house. But the overwhelming majority of the time, we're not there. When patients are in a hospital, even if the medical team is not near their bed, they know in the back of their mind that there's a medical team on call. They know that they're there. You don't need to create a sense of security. But in their homes, you need to artificially create the sense of security for the times that you're not there. Do it by being on call, literally on call, 24/7, 365. Make sure that you answer the phones in an immediate fashion. Make sure that there's always somebody able to hop into a car and get into their house with a very reasonable time frame. Somebody quoted 2 hours a day, 2 to 3 hours, reasonable time frame. Use electronic devices if you can, passive and active sensors. Use telemedicine so you can make telecommunications from afar, giving a sense of security. Leave in the house pharmaceutical and non-pharmaceutical tools that they can help themselves in specific medical situations. And make sure you don't leave the house until the primary care provider knows how to use these medications, when they feel safe and comfortable enough to do it. But the most important thing in creating a sense of security is give information and explain and explain and explain. The more you explain about possible scenarios that might happen, especially the scariest ones, what are they going to do when it's painful? What are they going to do when there's shortness of breath? What do they do if it's a panic attack or uncontrolled diarrhea? Explain to them what's going to happen. How are you going to help them? What is the protocol? This information is very, very important to creating a sense of control. Information that you give in advance is a powerful tool. Explanations that you give in hindsight is an excuse. Okay? Now, these were just 4 tools. Observe and absorb, be prepared to be surprised and improvise, ask for permission, and set the grounds for when you're not there. Now, you're all experienced in the art of taking care of people in their own homes. So I'm sure, and I welcome, any suggestions that you have to add to this list. It's not the Holy Bible. We can change it, we can edit it, we can add and subtract things. The last thing I'll say is that the fact that history is changing and medicine is going back home is also a great opportunity for us as healthcare providers. If you entered your profession because you're a professional, you're a person who likes people, because you're a human being who loves human beings, and you enjoy the art of caring, then the fact that medicine is moving back home is a great opportunity. It's an opportunity to fall in love again with what you're doing. As one of our nurses told me once in Sabar, she said that in my previous job, I used to tell myself in the morning, I'm going to the hospital. Today, in the morning, after visiting people in their home, I tell myself, I'm going to Mrs. Levy, to Mr. Abdallah, to Mrs. Gonzalez. Whereas before, I used to go to hospitals and take care of patients. Today, I go to homes and take care of people. Thank you very much. We have questions?
For one question, please.
An easy one, please.
Easy.
Somebody's raising their hand there.
Hi Ron, I thought that was fantastic and I would love to see that on YouTube for induction of new staff for home visiting. That's all. Can you hear that?
No. Can you say it again, please?
I thought that was fantastic and I would love to see it on YouTube so that we can share it with new staff as an induction tool for home visiting.
Thank you very much.
Thank you.
Can you say it again?